Good afternoon, everyone. I'm Maria Santiago. Many of you know me as Teng from Cohen Children's Medical Center in New York. On behalf of my web committee co-chairs, Mitzi Go and Annie Coates, Annie is also our PEDS web committee co-director with Christina Gaida. We would like to welcome you to this afternoon's Journal Club webinar. We're really pleased to have Dr. Aoife Corcoran from Children's Hospital of Philadelphia, who will be presenting the article Diagnostic Yield of Endobronchial Ultrasound and Virtual CT Navigational Bronchoscopy for Pediatric Pulmonary Nodules, mediastinal lymph nodes, and thoracic tumors in children, published in Pediatric Pulmonology this past November 2023. We're joined in our panel with a number of distinguished pediatric interventional bronchoscopists, Dr. Joe Piccioni from Children's Hospital of Philadelphia, who is a senior author on this article, Drs. Dan Banscotter and Gregory Berg from Cincinnati Children's, Dr. Didi Vicencio from Mount Sinai Kravitz Children's Hospital in New York, and Dr. Kimberly Caspi from Montreal Children's Hospital. Dr. Anila Bidwala from Children's Hospital of Montefiore will be co-moderating this session with me. Dr. Corcoran will give a 20-minute presentation of the article, after which Anila will lead the discussion with comments from our panelists. We will then open up the floor for discussion and questions from the audience. And please write your questions in the chat, and Anila will field them to our presenter and the panelists so that they can respond. And if you'd like to comment or ask a question out loud, you could hopefully raise your hand and unmute yourself, and you can make the comment. So we're really looking forward to a great discussion. And without any further delay, Aoife, the floor is yours.
Alrighty, thank you very much. So just to say, I have no disclosures for this presentation. So as Tang mentioned, we published this year in Pediatric Pulmonology, and I just want to say a quick thank you to all of our co-authors. It was a big project, and I really got a lot of help on this. So just to start us off, to kind of orient to what we're going to speak about today, we have endobronchial ultrasound and CT navigated bronchoscopy. So EBUS is just short for endobronchial ultrasound. We have two forms. There's linear endobronchial ultrasound, which is essentially a large bronchoscope. It's got a 6.9 millimeter outer diameter, and it has an ultrasound transducer built into the tip of the scope. And so you can see on the top image that kind of pink kind of face of the scope. That's the ultrasound transducer. And if you look down, you can see this kind of schematic of the bronchoscope pushed up against the bronchial mucosa. And then it's ultrasounding that structure that's underneath. There's a working channel which you can put your instruments through. So primarily it's going to be a needle. And so you can see in the picture and then also in the ultrasound image that the needle is entering that structure that's kind of just beneath the bronchial mucosa. So this is most commonly used in obviously the adult world for staging of lung cancer. So they're sampling the mediastinal nodes to really stage the cancer and see where the spread is. So this is just an image of on your left of kind of the nodal stations. And so when you're driving the scope, you're really trying to suppress all those the things you've been taught about not hitting off the wall, and you're actually trying to position yourself against the wall. Again, like any other ultrasound in any other part of the body, you have to have contact with the area that you're trying to ultrasound. So you'll have the scope alongside, kind of facing. If you're looking at those, if we look at just at the carina, so the subcarinal nodes, station 7. You're going to have the scope pointing into that area, so up against the bronchial mucosa. And so if you're going down the right side, you're going to be driving backwards down the right side, so that you're looking in at the carina. And again, this is just one of the images from the paper itself. So again, on the right here, we're looking at the ultrasound view that the scope is giving us. So again, like any other ultrasound image, you've got your transducer view from the top down, and the structure that's indicated by the yellow arrow is the capsule of the lymph node. It's usually pretty hyperechoic, so you've got the kind of bright white down the bottom, and then you can see the needle actually entering the lymph node. So when we're talking about sampling lymph nodes or sampling masses, you're actually watching your needle enter the mass under ultrasound guidance. When we talk about radial EBUS or radial, it's a radial probe. And so this is different. This is not a scope. This is a probe that's inserted through the working channel of another bronchoscope. So you need a channel that's big enough. It can be 1.7 millimeters if you're just using the probe alone. If you're going to use the guide sheath, which is just really a plastic sheath that the probe can then go through, you do need a channel that accommodates 2 millimeters. And so this probe, it's a spinning ultrasound probe. So it's giving you a constant 360-degree view. And that's what it looks like at the top of the image. And then again, the schematic is showing it going through an airway into a lesion where it's concentric. So the airway is kind of going into the center of the lesion. And that's the image that you're going to see then on ultrasound. These are just two more radial EBUS images. And so image A is actually showing us an eccentric lesion. So this is where the bronchus doesn't go directly into the lesion, or the lesion doesn't surround the airway entirely. It's really just off to one side. And so you're getting that spinning ultrasound. And so the kind of inferior part of that image is going to be your abnormal tissue. In contrast to B, where you can see that it is, again, it's in the center of the lesion, and so you're getting that 360-degree view. The other modality the paper talks about is virtual navigation bronchoscopy. So the system that we have at CHOP is called the Archimedes system, and it can reconstruct CT scans, and that they do have some specifications. You need to have image slices that are 1.5 millimeters thick, with a depth of 0.6 millimeters. So we plug this into the software, and this image kind of gives you a composite of kind of all the steps, but you plug your image in, and then the green sphere is actually placed by ourselves. So we've obviously identified the area of interest. We place the green sphere, and then the software calculates or reconstructs a virtual bronchoscope, and then a path to that lesion based off the CT scans. So again, this is a little bit of a busy image, but so we've placed that green sphere. If you look at the bottom panel center image, we've placed that green sphere. The CT software has reconstructed this path, and then you can see kind of the overlay of the airways, and then that blue line is kind of our path. If you look up at the top image, that's going to be the CT navigation software superimposed on top of a live bronch image. So this is me looking at obviously our software, but it's the input, the video is from me doing an actual bronchoscopy. And so you can see the green sphere is kind of in between those two airways. And so if we look down at the bottom panel on the far left, that's the 2 millimeter forceps actually entering the lesion. And then there's a radial ultrasound image of us confirming that we were in fact in the lesion. So hopefully this plays. This is just a video kind of explaining the actual process, probably a little bit better than I did. So this is courtesy of Joe and Pelton. And so you've got your live bronch image, and then in the center you've got the software system. So you kind of going through the CT scan. So again, we're using the radial EBUS probe just to confirm. And then you're comparing to, obviously you're going to have fluoro in the OR for this. So you're going to confirm your location. Again, so you've got your live bronch image, and then your reconstructed image or bronch path. So it is very helpful when you kind of get further out, when you do have those segmental airways. It's a little bit easy to kind of get lost as to, which way is up when you've turned to kind of locate yourself. Great. So the safety and feasibility of both of these modalities has been demonstrated in children in numerous case reports. And so the purpose of our paper was to really provide a largest report to date of the use of these. in kids, and also provide kind of that further data that supports the feasibility, safety, and also improved diagnostic yield of these modalities. So we conducted a retrospective chart review of all patients who underwent EBUS procedures, both radial and linear, and the virtual navigation bronchoscopy after we got IRB approval. Yield was something we really focused, it was the main focus of the paper, but it was something that we had really long discussions with. We had 2 adult colleagues that were involved in the paper, and they were very involved with the establishment of the program here at CHOP. And so we all felt very strongly that, particularly in procedural papers, how the yield is calculated and being very transparent about that is really, really important. And things can look a lot worse or a lot better, kind of depending on how you look at the numbers. So for us to define our yield, we calculated positive or negative results from the procedures. We used in where the procedures where there was a diagnosis that was ultimately found, because that way we could really define true positives or true negatives. And then we calculated the yield as true positive plus our true negative divided by our total number of procedures. We did have some inconclusive results, and I'll speak about those a little bit later. And so they were removed from the denominator because we really couldn't analyze them as either positive or negative. So we had 60 procedures in 56 patients, spanning between January 2015 and May 2023. 50% of our patients were female, and we had a pretty wide age range from 2 all the way up to 22. Ventilation was provided by LMA in over half of the procedures, and then an endotracheal tube in the remainder. And I think that speaks to one of the key things when we think about these procedures in children, specifically the linear EBUS is really we're very limited by size. The adults, they do these every day. They just throw in an 8.0 endotracheal tube. They don't even think anything of it. And so really that's we're not afforded the same luxury. So when we looked at pre-procedural indications, mediastinal lymphadenopathy and pulmonary nodules were really our main 2. We did have kind of coming in a little bit after with some hilar lymphadenopathy and then a scattering throughout the rest. For our patients, infection was a concern for a lot of patients, and so we did have just under half of patients on antimicrobials at the time of their procedure, and then again a little bit of a spread through the ones that had some exposure kind of in the preceding week. We did have just over half of our patients were immunodeficient in some way, and they either had a primary immune deficiency, were on an immunomodulator, or had a transplant of some kind or some chemotherapy. And so as far as the modality, we had a decent spread. We had about 40% linear, 43% radial, and then a kind of a mix throughout the rest. For the biopsy method, transbronchial needle aspiration, that's what TBNA stands for, is really the standard with linear EBUS, and then moving more towards the radial EBUS, which are going to be looking at more peripheral lesions, and you're going to be just doing transbronchial biopsies with forceps. For biopsy location, right lower lobe was our most common spot, and then our subcarinal nodes were the most common when we were sampling a lymph node station. And our nodules were kind of in between that 1.5 to 2 centimeter range on imaging. That was the most common. And so as far as diagnosis, as I said, infection was a concern for, for many of these patients pre-procedurally, and so that ended up being our most common diagnosis. We did have, a fair amount of malignancy diagnoses for a pediatric study. Obviously in the adults, it's malignancy or not. And then sarcoid was a close third. For the patients that required additional intervention, so we did have 14 of those that went for open biopsies or a kind of combination of either cutaneous or open biopsies. From a malignancy standpoint, they all ended up being Hodgkin's lymphoma. And so when we compared yield to kind of what they see in the adult literature, this was pretty common. So we had about a 40% yield for lymphoma, and that's traditionally what they see or what they had seen in the adult literature. Things have changed a little bit now with the advent of cryobiopsy and the smaller probe, but that wasn't in use for these procedures. We were 100% for our any solid tumors that we were concerned about. And so to just go over kind of how we broke down the yield again. So our yield was 76%. So those 76% of the patients really avoided any further open biopsy. When we looked at linear and radial yield, kind of a little bit more individually, we did have some diagnoses that, or some patients that went on to an additional procedure that then got the same diagnosis as the original EBUS procedure. So they were kind of included in our positive yield for both linear and radial. Infectious yield, I think, was something that we were really happy about, and something that really stands out, I think, for the paper. And so when we looked at patients who were on antibiotics at the time of the procedure, really reinforcing the data that's already out there that it does affect your yield when you're looking for infectious etiologies. And so positive cultures were obtained in 82% of those who were not taking antibiotics at the time of the procedure, compared to 60% of those who were taking antibiotics. And then, as I said, when we looked for infectious etiologies, all the patients got a BAL as kind of standard as part of their procedure. They were getting a flex bronch, they were getting that anyway. And then the EBUS or VBN procedure was kind of additive. And so when we looked at BAL alone versus BAL plus biopsy, we had a 77% increase in our infectious yields. These were clinically significant pathogens. We deemed that as ones that were treated. So if the team acted on it, it was deemed clinically significant, and our ID colleagues were pretty involved with that. When we broke this down further, into our immunocompromised patients, the yield was even further increased to 88%. And so you can see in the image on the right picture is really just showing kind of the overall yield, and you can see that it is higher compared to BAL alone. So again, adding to kind of that feasibility and safety data that we talked about, we were able to find the lymph node or the abnormal parenchyma, 94% of the patients. And when we found it, we were able to biopsy it in 93%. We had very low complication rates. 96% of our patients had nothing happen, and we had no pneumothoraces, which is obviously in contrast to any child that undergoes an open biopsy. We had hemorrhage, Nashville grade 1 and 2, which is very low level. And the most you're doing for those is maybe putting a little bit of Afrin or cold saline in the airway. We had no post-op complications. We did, in the majority, and we did have 2 patients that escalated to ICU, really needing probably a little bit of positive pressure post-anesthesia more than anything else. And then when we compare that to the children who went either a percutaneous or an open biopsy, nearly 40% of those patients had a chest tube. Some ranged as long as nearly a week with their chest tube, and had certainly more days of analgesia compared to the patients who did not undergo an additional intervention. I think this is a nice picture as to how EBUS can be really an outpatient procedure. So 42% of our patients went home after their procedure. Everyone else, there was one patient who was a planned admission to the floor, and then everyone else either went back to the floor or the ICU that they came from. Just a little note on the inconclusive patients. So we did have 12 that were kind of inconclusive from a final diagnosis standpoint. We had 2, unfortunately, that were lost to follow-up. 4 patients had complete resolution of their pulmonary nodules in the absence of any treatment. 1 patient had a presumed pulmonary manifestation of Evans syndrome. Another patient had a rare pulmonary manifestation of PLVA and has since recovered. And then 4 of our patients had a history of bone marrow transplant, were very, very unwell in the ICU with a presumed pneumonia, and were on pretty much every antimicrobial therapy you can think of. 2 out of those 4 patients did undergo open biopsy that still remained inconclusive, despite obviously larger tissue samples and extra stains and cultures. So I think the take-home points really from our paper, it's safe and it's feasible in children. This tissue acquisition really increases our yield for infectious studies. It offers an outpatient alternative. I think pediatric interventional pulmonology, as a whole, is a growing field. We're offering minimally invasive treatment and diagnostic options for children where the alternative or the norm has been an open procedure or certainly more invasive procedure. So thank you everybody for listening. Hopefully that wasn't run through that too quickly, and some references for everybody's.
Great. Thank you so much, Dr. Corcoran, for such great presentation and such impressive results. I would like also to thank all the panelists and participants for being here for this productive discussion. And now we are open for questions if you have any.
I can go first. I have a question for you, Aoife. One of the things that I think we struggle with is what do you obtain first, the BAL or the biopsy? And do you think it matters?
We usually do a BAL because we don't want to have bleeding or a bloody BAL after we biopsy. So that's been traditionally our approach. Same kind of when we do our transplant transbronchs as well. But yeah, that's been the. I think sometimes we've had, we'll definitely do all of the I suppose information gathering side of things. You don't want to do radial into an airway that you've put a load of saline into, because although we've tried it, but we surmise that it's probably going to may look a little bit different, just because you're disrupting that kind of tissue interface. So we try and not kind of get all of our, figure out where we're going after. If we want to BAL in the same place that we're going to take a biopsy, we'll do kind of, a lot of our navigating beforehand. We don't traditionally use the sheath as much, the guide sheath that I spoke about for it's usually just size dependent. The kids are a lot smaller, and so it's rare that we will have one that we can use the 4.2 scope on for the 2 millimeter channel. I've been speaking with adult colleagues as well on their side. They don't really feel like it helps that much either. I think it's, the goal of it is to kind of hold you in the spot, so you can biopsy a little bit easier. But a lot of people will just kind of mark it on the fluoro with a little bit of tape, which doesn't seem very scientific, but tends to work.
Yes, so I do have a comment in the chat that Roger Kim says that he believes that the guide sheet has been discontinued. Or you?
Yeah, we haven't used. I've never used it, so.
And then, so it's only an endobronchial lesion that can be biopsied?
Nope. These are mostly transbronchial. So it's actually a parenchymal lesion that we're going after. So oftentimes it's certainly obviously you can biopsy an endobronchial lesion, but most of the time you're looking at a CT scan where you've got either a pulmonary nodule or a pulmonary opacity, and so you're navigating with whatever tools you're using out to that point, and then confirming your location with a radial ultrasound, so you can make sure that you can see that abnormal tissue, and then you're taking usually transbronchial biopsies.
And what was the youngest child?
2.
Age 2, right?
Yeah.
Sorry, I'm one of the Pullman attendings at Columbia. This was a great talk, and I had a couple of questions, but I won't ask them all. But I guess my first question is about the group of people who had a repeat procedure, and for all of those, or it sounds like some of those were people who you had at least a suspected diagnosis on the. So can you talk a little bit about what was the reason in some cases for having a repeat procedure? Or was there also some of that group inconclusive and then had a procedure? And I just wanted to hear more about that population.
So definitely there were some that, so really it boiled down to the primary teams. Obviously we're a consulting team, primary team's comfort level with our diagnosis. So, it's obviously relatively new. It is very new in pediatrics. So a lot of the groups that we were dealing with, are oncology or ID who are used to biopsy, but used to, an open lung biopsy, or a CT guided biopsy with IR. And so I think the push for those additional investigations was primarily down to the comfort of the primary team to say, this is actually what this is. And so that's why we've kind of made a point of looking back at those ones that where the actual initial EBUS diagnosis or VBN diagnosis equaled the subsequent diagnosis. So yeah, that was the main reason.
Got it. No, that makes sense. And in cases where the EBUS diagnosis might have been inconclusive, but it wound up clinically that the patient didn't wind up needing any subsequent procedure, or it resolved, or whatever it was, did you count those people in your, like, towards your numerator essentially in your calculation of diagnostic yield? Or
yeah, where there was where we could never find a diagnosis, they were removed, because we couldn't really say if they were a true positive or a true negative.
Sure. Okay. Is it okay if I don't want to monopolize you, but my last question is, what's the vent strategy that you use for the robot, or for the like, do you and I guess like vent and airway strategy, I guess. Yeah. Do you deal with a lot of, like,
we don't have a robot yet, but,
or not? Okay.
Yeah, but for those, it really depends. So, like, if you have a big teenager that you can get an 8.0 endotracheal tube in, you're fine, right? You're going to do it as the adults do. For the smaller kids, it always becomes, it's always a discussion. You know, we're not the favorites of the anesthesia team down here when we do these procedures. So usually we're using an LMA, and so, you know, I think we had such a spread of patients. We had some, you know, relatively, like, healthy children who had a pulmonary nodule who were coming in, and then we had some very unwell, you know, bone marrow transplant patients who were quite sick. And so it is pretty dependent. But I think, you know, while we have the instruments in the airway, it's not the easiest to ventilate them. And so oftentimes when we have the bigger scopes in, they'll usually hand ventilate for some of them, just to be able to kind of bypass. Obviously, you've got so much resistance with the scope in the airway, and so there's not really a set, you know, strategy that we use. I don't know if any of the panelists have more to comment on that, but it's kind of, you know, it's pretty individual, and really kind of dependent on what we're doing at the time, or what we're doing in the airway.
Okay, great. So I'd like to invite Dr. Vicencio and Dr. Berg to comment on how it's different at their center and what's their experience.
Greg, you want to go first?
Yeah, so we don't do a radial EBUS here right now. When we were targeting peripheral lesions, we were doing cone beam CT, and augmented intraoperative fluoroscopy, overlaying how that looks, and that's how we're targeting our distal biopsies. I think the other thing that's come up in the chat too is that a lot of this was really kind of laying a lot of foundation for interventional diagnostic work, and in the time that this has been going on, we've also had the smaller cryoprobe become available, which is really changing this whole field, and for us it's improving diagnostic yield tremendously, even over the forceps biopsy. So I would say that, you know, we're doing EBUS, linear EBUS, or the mediastinum, very similar to the team at CHOP, that will often make a track with the needle through the EBUS, and then we'll go through that track with forceps or cryoprobe. I'm kind of starting to evolve toward going just to cryo biopsies through those tracks. I think Eric's on here too, and we kind of go back and forth in the OR about whether or not the forceps is going to help us. Yeah, so I think that's kind of where we are. I don't know if that answers the question exactly. I think different navigational approaches are out there, and they're becoming more and more available in the pediatric world, which I think is great for helping us get some answers without open chest procedures.
I don't have a whole lot to add. I will say that Greg touched on this already, but I think that these navigational procedures are probably going to be very institution dependent, based largely on the equipment that's available. I started using some of this navigational equipment many years ago, and back then it was electromagnetic navigation. And one of the things that I will comment on is that the software itself is very similar between a lot of these platforms. You know, whether the photos, the modern photos of things like Archimedes or robot software are gorgeous and probably more accurate, but especially for some of the larger lesions that you might see, abscesses that won't go away and things like that, the navigational software in and of itself is actually quite good and very helpful in needle placement, even if you need to just use something like fluoro. Smaller lesions, then absolutely, the software you know, we have a robot, we rarely use it, and it's just we happen to share a suite with our adult colleagues. But I think that there are a lot of navigational tools that are available that can accomplish very, very similar things. And in the future, I think it might be nice to separate out, what's better for peripheral lesions. Is radial EBUS sufficient? Do we really, really need $1 million robot to actually get to the lesions that we're going to be looking for in pediatrics? So that's the only comment that I have regarding that. If you don't mind, Eric's had his hand up very patiently for a long time. So
yeah, he was next. Yeah, Eric, please go ahead.
Thank you. And this is great stuff. Curious on two parts to this. Number one, you show with this that you can get good diagnostic yield and you can do things really quite safely. I think there was 0 pneumothorax and minor bleeding in this case. So in a way, this lowers the barrier of entry to being able to obtain specimen in patients. With that, how does that change what your inclusion criteria would be for pediatric patients with peripheral nodules?
Yeah, great question. I think, we, all of the patients in this paper were kind of, pre-selected. Obviously, they were, screened prior to us doing this. This wasn't just everyone with a nodule that we then tried. They were either put through the navigation software, or it was, to see if it was feasible and we could, reach the lesion. I think that's still applicable. Like, I think, there's, we've been sent a couple of cases where, there's just, it's either off in the abyss and it's really not going to be accessible, or we look at it and we say, actually, this maybe is more accessible with IR. I think the one thing I've noticed, I guess, with kind of, as more people at CHOP and more departments hear about us being able to get tissue this way, we then tend to get, sometimes get requests that are maybe a little bit inappropriate. Like I have 2 platelets, and can you get tissue? And you're thinking, I wish, but like, that's probably not going to end very well for any of us. And so I think, the more we, I suppose, disseminate the information, and Joe has been a big proponent, obviously, in this, and we spoke about this a little bit earlier with Greg. We're kind of going around to those different departments that see these things, see these nodules. Obviously the onco division, rheumatology, places like that maybe don't think of us first at all. I think that's been a big push for us. We would rather than think of us first, then think of the surgeons first, or IR. And so I think partnering with all of those is really going to try and help us increase that volume. I think there's an old, you see it in pretty much every paper that's written on pediatric interventional pulmonology to say, we don't have the volume. I think we do have the volume. I just think the people who have the volume don't know about us. And it's not to say that we can do this on absolutely everybody, but I think we can certainly do it on more patients that are probably coming our way.
Well, part of the question I was trying to get at there was, I agree with you. I think there's a lot more patients out there. In terms of patient selection, we probably don't want to be doing everyone who's got an incidental finding on a chest radiograph, especially for places like us in the histo belt. So how are you guys trying to navigate that, pardon the pun, with the fact that you can get to things in increasingly smaller, increasingly different locations safely? Like, who are you trying to target? Is it is it likely cancer? Is it infection that's not responding? Like, what in that regard?
Yeah, I think both of those. Certainly, we're seeing a lot more kind of referrals from the onco group, for concern for recurrence, or kind of any larger central stuff. We had a child recently, we were all ready to go, turned out to be a bronchogenic cyst. So, and then, those kind of infectious, infectious etiologies where we're, where there is a concern, that there's an infection playing a role, but, getting tissue, how is that going to inform what they're doing? And so that pathway is a little bit less clear, I think, in terms of like how we find some of those. I had a kid last week that kind of came through our ENT group, who had an abnormal chest CT. So I don't think we fully ironed that out, and that side of it. We've had a couple obviously from within our own group, like from pulmonary sarcoid, but again, it is still somewhat kind of dependent on what's kind of coming through. I don't think we've got a great pathway for those yet.
Okay, great. So I do have a few more questions in the chat. How much has your procedural technique changed since the advent and increasing utility of cryobiopsy? So either Joe or Aoife, anyone, can you answer?
I can take this one, or at least take the
Yeah.
start of it.
Yeah.
I think, with the larger cryoprobes, we were more hesitant to use them, but when the 1.1 probe came out and some early data from both adult and pediatric transbronchial lung biopsy using this probe came out, I became more reassured, and we started doing it in May, and have been very happy with the results. I have just a couple of slides to show a comparison. So this is the cryo probe, just to give you a sense of what it looks like. The 1.1 probe is the one we use. And a comparison with forceps, it's quite obviously better tissue. And when you look at it under the microscope, not only do you get a much bigger chunk to start with, but that crush artifact that you see with the forceps really isn't there. And so you have, maybe a sample 4 times as large, and you can use 100% of it as opposed to 50% of it, trying to look in the center where the tissue isn't crushed by the forceps. And just another photo here of example of cryobiopsies. You can see an airway and then any adjacent alveolar tissue. I mean, when we think about the lung transplant kids and we do biopsies, we're looking for you can count the number of alveoli. Here, you get a really good chunk of them. And then likewise in the lymph node, where we really had the lowest yield was for lymphoma. When you have a cryobiopsy of a lymph node, it's just so much bigger and more useful. And this recently got published in Ped Pulm, but it was a kid who I swore was going to have tuberculosis and turned out to be a Hodgkin's lymphoma. And our pathologists were kind of blown away. They said this is not a minimally invasive sample diagnosis. You need an excisional biopsy to be confident about a Hodgkin's if it's a primary. And so I think that is definitely a game changer. Knowing we can get to these things and now knowing that the tissue quality is so much better, I think it's going to open some doors.
Great. So another question in that regard, does your center use a multidisciplinary case discussion, including radiology and pathology, as a part of procedural planning?
We wish. No, we're trying to break into those tumor boards and places like that. That's our dream, is to be able to be involved in those. It's still a little bit case by case. But I think that's definitely the future for a lot of this. I think that's when I did a rotation at the adult hospital that's beside us at Hope, and that's how they go about them. But I guess it's cancer or not for there. So I think because we're dealing with a little bit more of a spread.
I think that's a great concept, so
100%, yeah.
We do participate in some tumor boards here. There's multiple different tumor boards at Cincinnati. And I'd say that we're on speed dial for interventional radiology and oncology and surgery to come join some of these, depending on the primary oncology division or segment.
What's the youngest age you can biopsy?
The youngest age in our paper was 2. And it's kind of all really dependent on size and location, like what you're actually trying to biopsy versus, peripheral versus something central. Can you get the EVIS actually into their, the linear scope into their airway? Do you need to go transesophageal? So that's the youngest we got was 2. He was very small 2-year-old. He weighed like 10 kilos.
And there are a few more comments and questions. Is there a need for rapid on-site evaluation during the procedure?
So we don't have that at CHOP. We don't have it available. I think there's a little bit of adult data to say, that it's not as helpful anymore. Sometimes it would be lovely for them to be able to say, nope, that's not the lymph node. But we don't have it at CHOP, unfortunately.
Okay, so Kimberly, Dr. Caspi.
I had a question, going back to the biopsy and cryo biopsy as an additional way to get better specimens. How many biopsy passes and samples are you trying to get forceps compared to cryo?
We've done what, 3, Joe? Is our most?
3 passes with the cryo, yeah, 2 to 3, depending on how small the
Yeah.
kid is, what we think their bleeding and pneumothorax risk is, or and maybe less so, are they going to have a pneumo, but are they going to tolerate a pneumothorax? If they're really fragile, we may just do 1 or 2 passes, but I think our goal, if the kid will tolerate it, will be probably 3 passes, with a freeze time of 4 to 6 seconds.
If you're starting to get a little bit of bleeding, Kim, I think becomes a little bit hard to figure out if you're just getting blood popsicles. Then as the more you do.
And the smaller kids, you might do fewer passes. If it's diffuse disease, you don't need to use the imaging technology to get to the lesion. You can do younger kids, but I do worry, certainly anyone under 12 to 18 months doing a cryo biopsy. One of the questions I have is it too much tissue for a kid at that age? And what's the pneumothorax risk look like in that age group compared to the others? One thing we saw is that the pneumo risk in the image guided is less than expected for general fluoroscopic guided transbronchial biopsy. We didn't have any pneumos, I think, in this cohort of 60. I don't think we've had any. We've done about 100 now. I don't think we've had a pneumo yet with the image guided biopsies.
Nope.
So we're either really lucky or we're able to avoid the pleura because we have our landmark, but much more in focus using this software in the eBus.
Dr. Vicencio, you have hands up.
Aoife, I'm still, perhaps maybe I shouldn't be, but I'm still a little reluctant not to use, for example, a balloon blocker for peripheral biopsies. What's your practice? Do you think that they're necessary? Sometimes they're a little bit of a pain, right? And
Yep.
For the smaller kids, then you need a little bit more airway. What's your practice there regarding prevention of complications like bleeding?
Yeah, so we've erred on the side of caution, and we've used them for all of the cryo biopsies. And you're right, it's another whole conversation at the start of the case as to who's putting the tube in, where's the blocker going, size wise. But since we had just it's relatively new for us to be doing cryo biopsies. We're also not doing them every day, and so we kind of have the thought process that I'd rather have it there than have to be placing it, in response to something as well. I know, when we went to AIBIP, there was some, lots of fantastic lectures, but there was a pretty big symposium on cryo and cryobiopsy, and there was, a spread even among the adults. Some were still using it, some just figured that, the 1.1 the freeze rate, the freeze diameter just wasn't causing as much damage as they've been seeing with the bigger probes in the past, and so they felt comfortable not using them anymore.
Thank you.
Dr. Das, you have hand.
Going back to the question of how many passes when it comes to mediastinal nodes and the addition of cryobiopsy, for me the challenge always ends up being how many. I have a micro cup, an RPMI. If I have rows available, they usually take the first 1 or 2 passes and then formalin. So I'm trying to find a strategy for myself that works when it comes to passes. And I want to see y'all's experience when it comes to TBNA to start with, and then cryobiopsy. In my head, I'm thinking like 4 passes total with the TBNA and maybe 2 to 3 with the cryobiopsy if I can, get in every time. But just wanted to get y'all's thoughts.
Yeah, and I think the adult literature, I think it's like no more than 3 really doesn't really add to your yield for for passes. I think the big thing I took home from my 2 weeks with our adult colleagues was the number of needle like actual needle jabs, I suppose, when you're actually in the lesion. They do up to 30, and that may just be institution dependent over there. But that was something that we, well, at least I changed for the next one. And then I guess for cryo as well, depending on whether you're going after a peripheral lesion or if we're talking just more about central lesions or nodal biopsies, there's often the struggle to get the cryoprobe actually into the lesion can be difficult. And so They would never do more than 3 on each, but sometimes it was the air would just get so beat up that you lose that needle track, you lose that needle hole, and because you can't actually make a needle hole with the cryo, they would do if it was just getting too hard, they would usually stop at 2, but that was just another kind of added procedural, I suppose, side of it that I hadn't really thought of. I kind of figured, I also figured it was just everything was going to be so much easier in adults. So, so it was nice to see them struggle a little bit as well.
Dr. Caspi, what's your experience at your center, or any other comment?
Yeah, so I'm still pretty new to practice here at the training. I'm in a center where this wasn't a thing at all previously. Fortunately, I'm at a center that's a combination of a pediatric and adult hospital. So my adult colleagues and my adult IP are just kind of down the hallway. They've got 2 separate hospitals that are attached. So a lot of it has been collaborating with them on these, and we're still kind of getting our program up and running.
I think that's how everything started at CHOP as well. I know Joe can speak to a little bit more of that, but Andy and Dave from across the street have been a huge help for us. They've come over, even in my time, have come over to help us with some trickier procedures. It's always very humbling to watch them work.
Yeah, we would like to know more about that, like how to start and what were the barriers and what to anticipate.
Yeah, I mean, I'd love to have a webinar about starting a program. I think that would be really fun and useful, because that's where most people are at. We started in 2014, and I'd say for the first maybe 4 years, the adult interventional pulmonologists got privileges at CHOP, and they would come over for every case. But we, in the beginning, were only doing maybe 5 to 10 cases a year. So there was a steep learning curve at first and not a lot of volume, which is a big critique of why or how pediatrics is ready for this. But again, once we got our groove and got comfortable with it, one, we didn't need them to come anymore. We may talk through the cases with them prior to the day of the procedure to say, here's what I'm thinking. What do you think? Does that seem sensible? But now we do them on our own. And the more we've done, the more awareness we've raised within the hospital, the more referrals we've got. And so I think that bar to get enough procedure volume in to maintain your skills and be good at this has now been surpassed, but it took a long time to get there. We didn't have cryotechnology at the time we started the program. I think that's really what's going to help this take off. I think now not only can we get to these lesions, the technology there has improved, but we can get really high quality tissue. So I think the field is ripe to take off.
Jill, can I piggyback on that for a second? Just so you know, on your suggestion, David Shore will actually be giving a similar talk, a talk like that for the New York City cryo course. The bad news about that is that I expanded the attendee list, but there are only, I think, 2 slots available now. So.
Hi, my name is Sally. I'm one of the fellows at U of M in Michigan. Actually, Didi, I just sent you an email hoping to be able to attend the course in March. Because I'm
You
really
got it.
hoping...
I'll put you on the list right now.
Perfect. Thanks. I am really hoping to establish an IP program at Michigan. I know it's going to take a lot of work because for the most part, a lot of our kids are either being transferred or, the biopsies are going through the, surgeons. And so my question is, realistically speaking, how long do we think to establish a program from the ground up? How many years would it take to get a program built?
Joe, I'm gonna throw that one to you.
I think, it took us 10 years to get to where we're at now, but the rate of growth and the technology is so much better than when we started that I don't think it should take 10 years other places. We have the benefit of being a very large hospital, and so there's a lot more patients that might benefit from these services. The downside there is if I give a talk to oncology team, for instance, and I have 50 people attend, that's only a third of our team. And so it's really hard to reach everybody. So that's a unique challenge about a really big place. Um, I I think it depends on how quick things buy in. And I think any one thing, if you said, well, all we're going to do is lymph node biopsies, well, that's going to, you can focus there and it's going to grow, but I don't know how much overall growth you're going to see if you just focus on one thing. I think we talked here about advanced diagnostic, but when you include interventional cases, we're doing somewhere around 100 to 150 advanced diagnostic or interventional bronchoscopies here a year. So it's enough to maintain skills and kind of have a number of team members so that one person isn't on call 365 days a year. But I think it's the collective. I can do a little bit of this, I can do a little bit of that, how you build your program. And but I think if you have the capital support, if the institution either already has on the adult side this equipment or is willing to invest in it, I think, 3 or 4 years, you can get up and be a fairly fluid, functional IP program. I don't know
Joe,
what you
don't
think, because I
I
made that.
don't you think that having the adult interventionalists to like help you get it going, if they're interested to like help you out, it's going to be very helpful for building a program.
There's no formal training program for this, so
Yeah.
that's the only way to do it. Take
Yeah.
courses where you can, but you need a mentor.
But I think for the small programs, small or medium-sized programs, the challenging part is to convince the administration that, okay, it's worth buying the equipment. So I don't know how to start, like, going and, to the adult and using their equipment or having them come. I don't know. Any experience with the smaller programs?
I think cryo in particular for the smaller programs is probably going to be the entry drug or the gateway drug, because that if you can show like the ICU that you don't have to spend 4 hours at the bedside suctioning clots out of an ECMO patient, you still might spend a good bit of time there, but with the cryo probe, the efficiency is so much more. I think that's where you can kind of prove to the, no one's going to go out and buy a linear ebiscope, an Archimedes system and the whole lot, but especially if you have, if you've equipment on the adult side, I know even in my prior institution where I did my residency, they talked with their adult side and had brought over kind of equipment, specifically cryo, to help with an ECMO case after going to one of the courses. And so like that for them, they were like, oh, this actually is really helpful and is is time saving and cost saving in the long run. So I think it's going to be gradual, for the smaller programs, to show like this. Maybe you're not going to do everything all at once, but you certainly start in those areas, and then grow from there.
But many of the smaller programs are going to be more likely to have access to the equipment on the adult side, so that's an advantage.
Can I make a plug? Actually, I'd like to make a plug for the small and medium-sized programs. I mean, I come from a small program, and I think that one of the things is that, look, I myself get very, very jealous at a lot of things that Aoife and Joe and Eric and Greg are doing in their 600-bed hospitals that they never have to leave and, to get some really great cases. But I think that I honestly believe, number one, that this is completely feasible in any academic program.
Mm-hmm.
I think it's very important in any academic program. But I think that it probably should be approached, as Aoife had alluded to already, in a very, very staged manner. Not everybody needs to go out and start poking around at peripheral lesions. But I think that the skills that are acquired with relatively simple things like cryoprobe use, or even things like forceps and needles, those skills are transferable to some of the more difficult cases. And this is one of the things that we've been trying to highlight in some of the courses that we've collectively run over the past several years. Not everybody is comfortable with instrumentation of the scope, but very, very simple procedures like that are really, really going to help these programs take off. And I would really encourage even small programs. We're never going to be able to do that here. If you're doing pediatric bronchoscopy, I really believe that you can advance very, very slowly and deliberately into this field. And I think that it's going to be important for the entire discipline. That's my soapbox comment, so I apologize.
Edie, on that
I
note,
agree.
do you want to say anything about the AABIP and how the pediatricians get involved in that?
I might leave that to Joe and Eric, the chair and the co-chair of the newly formed AABIP as of April 2024. So, Joe, Eric, would you like to comment?
Let's give Eric the opportunity. I've said too much already.
Oh, Joe, I think it's your show as the chair.
So in February, we formed the pediatrics chapter of the AABIP. The AABIP is the organization that really developed the pulmonary training programs on the adult side and the board certification process for those one-year fellowship programs until very recently partnering with ACGME to be a dual accrediting body. There's now 40 some odd interventional pulmonary fellowships in the country, which is close to what we have for pediatric pulmonary as a whole. So I think it'll be a long time before we get to 40. But I think they have, over the last 20 years, laid the foundation and provided the blueprints for how to bring this into pediatrics. They've been very supportive of that. And so we now have about 45 pediatric members in the AABIP. And we have a strategic mission to accomplish the goals I think are necessary to get this field really off the ground. And we're very excited to work with everybody to do that. And I think, you know, one of the things we had a needs assessment survey we sent out. We had 60 plus responses. And one of the things that came very clear was that we need to partner with ATS. You know, this may be the foundation building association for us because they have the precedent set and the fellowship training programs under their belt. But our home is ATS. And so we need to find a way to kind of partner together to work on all these things.
Great. So I just have one more comment in the chat, and there was a great talk on cryobiopsy from the ATS yesterday, which included mediastinal biopsy. Have you engaged with your pathologist and oncologist regarding the utility for lymphoma to obtain that core biopsy that always wanted?
Yeah, I'd say these cryobiopsies are better than core biopsies. And I've gotten the pathologist to say that out loud. Sometimes I ask them more than once, because for the last 10 years, they've been saying how small our samples are. And the cryo is better than a core biopsy. So yeah, we engage with them on every case before, during, and after. And they put up with us pretty nicely.
That might be a stretch for some of them.
Yeah, I mean, I had a pathologist use the word generous samples.
Eric and I were just texting that back. I wrote it in the chat and he texted me it. We had, when our pathologist said, "Thank you for the generous samples," I did a double take.
Joe, can I ask a follow-up question? I'm sorry I didn't raise my hand, but in this regard, this is going to sound like a really dumb comment, but bear with me. I've over my experience, you know, having dual purposes for equipment, you know, crossing outside of pediatric pulmonology, is really, really helpful in actually getting hospitals to purchase equipment. If your pathologists are saying these are better than core biopsies, and you can pass that 1.1 through a core biopsy needle, is there a role for these things for liver biopsies or for X, Y, and Z?
Yes, Joe, I could comment on, we have an interventional GI program as well, and we share our processor for EBUS. And we actually work together on some of these advanced cases, sort of the interventional GI, interventional pulm, interventional radiology, and we'll workshop the cases and both go at the same time and see who's got the best approach sometimes.
Yeah, our interventional GI also bought a new EBUS processor, and only on the caveat that we could use our equipment with their processor. You're gonna have Joe doing flexible bronchoscopy liver biopsies, Didi, if you keep talking like that.
So we're at the hour, guys. Like, it's really been as we expected. It's like a great, stimulating discussion, and we really want to thank Aoife, for presenting like the data, and Joe, and all our panelists, and just you can just see the engagement from the audience in terms of like how helpful they thought everything was. Thank you guys so much. We're so excited to see where our field is going, and you guys are definitely like contributing to like exciting new things. Thank you so much, and everyone have a wonderful weekend.
Thanks, everybody.
Thank you.